What is the harm from a CBCT, and should we be using it more in routine orthodontic clinical practice? Welcome to this episode of Orthodontics in Summary. Today's episode is really looking at CBCTs. We're going to be looking at what the harms are associated with the use of CBCT and compare that to both medical and non-medical forms of radiation. This was one of my favourite lectures from last year's British Orthodontic Conference. It was given by Consultant Dental Radiologist Simon Harvey, where he gave his 3 facts of where we currently understand CBCTs to be in the use of orthodontics, as well as his 3 main incidental findings orthodontists should all be aware of. Just to recap, the podcast is the opinion piece of myself and the Orthodontics in Summary team. Now, the starting question is, what are the chances of causing cancer from taking a CBCT? Well, in looking at CBCT machines and taking a small field of view scan, how much radiation dose is emitted? Well, actually, when it comes to looking at modern machinery, and there's 2 that Simon looked at, the KAVO and the Morito X800, it was 16 microsieverts that get produced. Now, to put that into context, actually the dose from a full orthopantogram with a digital system is between 20 and 25 microsieverts. So actually a small field of view CBCT is actually less than taking conventional full orthopantogram. However, we need to put that into context. So what we're really looking at is the microsievert, which is a measure of the effective dose, essentially looking at the radiosensitivity of one part of the body compared to the other. Generally, when it comes to looking at radiation dosages, most parts of the head and neck region are relatively insensitive to radiation compared to other areas of the body. So Harvey put this into context and compared the FDA values of medical CT scans of the areas of the body. For example, the lumbar region, which has the lowest, is 1,500 microsieverts. An angiogram CT of the heart is 16,000 microsieverts. So we come to Harvey's first fact, and that is the effective dose in dental imaging with a CBCT are far lower than the rest of medicine. But that shouldn't give us a license to use a CBCT whenever we please. What about comparing radiation dosages from outside of medicine and dentistry? Well, there are 2 main causes, terrestrial radiation and cosmic radiation. Putting this into a tangible concept, a flight from London over to New York and back is 56 microsieverts. It was interesting to get the opinion from a cancer research trust, which looked at this and described this trip does not increase the effect of having cancer, even for frequent flyers. And this has been shown in the research that pilots who have this cosmic radiation dose exposed to them are not at any increased risk of cancer compared to lay people. In the UK, the annual background radiation dose a member of the public receives is around 3,000 microsieverts annually. Simon's second fact was that the effective dose in dental imaging, CBCTs, are far lower than natural background radiation. The next point Simon went on to make was looking at the statement from the American Association of Physicists and in Medicine, their AAPM. Now I'll quote their statement where they describe where the threshold should lie for medical and dental radiation dosages and concerns. So the evidence supporting increased cancer incidence of mortality from radiation dosages below 100 millisieverts, that's the equivalent to 100,000 microsieverts, is inconclusive. And what they described was how we shouldn't be highly speculative and discourage these predictions based upon a hypothetical harm. And that brings us to Simon's third fact, that the effective dose of dental imaging are very low and are very unlikely to cause or be involved with cancer. Looking at the material benefits we have in terms of diagnostics when it comes to CBCTs, well, now the classic example really relates to impacted canines, how the use of plain 2-dimensional radiographs still do not give confidence in both pathology and location. However, a CBCT will give clear imaging and understanding of the follicle, pathology and relationships, giving clinicians confidence in decision making. This is evidence now when it comes to changing plans for patients, comparing CBCTs to conventional plain 2D radiographs, and it was shown that between a quarter and up to a half of treatment plans changed. It wasn't the truest story, as some of these changes related to changing of traction and application of anchorage. However, true treatment plan changes, in my opinion, where we change from exposures to extractions or vice versa, occurs in 10 to 20% of cases when we look at a CBCT. And that's key in a study from 2023. We know the benefits from cleft in quantifying the amount of bone for surgery, as well as surgeons locating important anatomical landmarks. Coming through to the 3 key incidental findings orthodontists should be aware of. Number 1, dense bony islands. So what are they? It's a radiopacity with no radiolucent halo. They generally tend to occur in the mandibular premolar region, but it's not exclusive to it. They are harmless, and that is a key take-home message to reassure ourselves and our patients. However, we do need to factor them into planning, as they may resorb roots if contact is made. So we need to form our treatment plan around not moving teeth into these areas. Number 2, sinus mucosal thickening. So the antral floor, as long as it remains intact, is only of concern if it's greater than 5 millimeters. Otherwise, it is simply just a variation of normal anatomy. The 3rd incidental finding, trabecular pattern. This can be quite marked and generally tends to occur around the inferior dental alveolar canal. It has no corticated borders. Now, it tends to be more in children, and that's technically because of the physiological response of having more red blood cells and developing in that surrounding region. Again, it's incidental, nothing to have concerns of. Okay, so what conclusions can we draw from this? Well, CBCTs have a low radiation dose and exceptionally low risk of causing cancer. They give us greater confidence as clinicians when it comes to treatment planning and decision-making processes. One of the things that Simon also mentioned actually was that for pregnant women, we are allowed to take CBCTs as the irradiation is not in the pelvic region, and the CBCT view, unlike CT scans, the beam is horizontal, so there is no risk. So, with the radiation effective dose being so low for CBCTs, should we now use it as part of routine imaging in orthodontic clinical practice? Simon Harvey's answer to that was no. In fact, he went one stage further. He mentioned any type of X-ray radiation dosages for imaging should never go hand in hand with the terminology of routine. So what we've understood is that yes, the dosage has reduced dramatically and is far less than our medical counterparts. However, there is still a risk there for patients. It is greater for our younger patients, anywhere between a third to double that of our adult patients. So we still have to abide by the principles of ALOP and be as low as reasonable possible when it comes to using radiation dosages. I really enjoyed Simon's lecture. He gave a summary of the topic in terms of current understanding of radiation dosages, also the advantage of using CBCTs and where we should be using it more to be accurate and confident in clinical practice. However, it should never enter routine because of the small, minute risk of cancer being present and the nature of radiation dosages, especially for our younger patients. An excellent lecture. Hope you guys have enjoyed it. Please do subscribe and look forward to our next episode.